What's up? My name is Anna. I am a travel ICU nurse and I start CRNA school in 1 month. This is going to be what is a high acuity ICU and what do I need to look for in an ICU as a new grad. And timestamps are going to be down below so you can scroll along and find exactly all of the answers that you were looking for. What is a high acuity ICU? You might hear that term thrown around a little bit in nursing school and not know exactly what people are talking about when they say it. Acuity basically means very sick patients. And there are a couple of measurable ways to see how sick an ICU is. The first thing I'll say is to look at the number of drips that the average patient is on in the ICU. And by drips, I mean both sedation, inotropes, vasopressors, and antihypertensive drips. All of that will make a very sick patient. And then another way to look to see if the ICU is high acuity is by the number of beds that they have on the unit. A small 8-bed ICU in a community hospital is likely going to take less sick patients than a 35 or a 40-bed ICU in a large academic medical center. The next thing to look at is to try to walk through the unit when you are there to interview and look to see how many patients are on a ventilator or any other devices like CVVH, EVD, ECMO, balloon pumps, all of that good stuff. All of that together will kind of give you an idea of how sick the average patient population is, because not all ICUs take equally sick patients. And you want to be somewhere where you're going to be exposed to the sickest of the sick, and you want to learn as much as you can as quickly as possible. That's why you want to be in a high acuity ICU. So again, walk through the unit on your interview day, look to see how many patients are on ventilators, look to see how many patients are on drips. Also, the number of beds is a pretty good indicator for how sick the ICU is going to be. Larger ICUs are typically for sicker patients. Second point, once you are looking to start there as a new grad, you need to figure out how thorough your education is going to be. How long is your orientation? I would really caution against going somewhere that has an ICU orientation that is shorter than 12 weeks. 12 weeks, I think, is the bare minimum. When I was a new grad, I chose an orientation that was 20 weeks. That was pretty standard. Everyone got a 20-week orientation, and I felt very well supported through that. Honestly, even for new grads working in a med-surg, I think that they need 12 weeks of structural support just so that they can get their bearings and figure out how to be a nurse, because you just don't do all the mechanics of that in nursing school. Your orientation, you need to be asking, how long is my orientation? Am I going to have one primary preceptor, or am I going to be with a bunch of different nurses and not necessarily have consistency? Do they have a new graduate residency program? What is the structure that is offered within that new graduate residency program? Is there a critical care residency program that's separate from the general new grad residency program? Because oftentimes these new graduate residency programs are for all new grads in the hospital, and you're gonna cover topics like self-care and charting and heparin drips, but there's not always structure for critical care education, and new grads need that. They need a little bit of extra support, and they need critical care topics to go through. All of that is something to look for, and I would recommend starting somewhere with the highest acuity possible and the best structural support for new grads possible. And often those two go hand in hand, and these large academic medical centers usually have very good training programs with a lot more support than some of these smaller hospitals. The next thing is there a best ICU for CRNA school? I, first of all, am not a CRNA, but having just gone through the application process, I will give my opinion to people who are coming after me. And I'll say that there's no best or only way to get into CRNA school. What you're going to be looking for is a patient population that is very sick, where you as a nurse are going to have a lot of autonomy, where you're going to have very high acuity regularly and consistently, and where you are constantly challenging yourself as a nurse. And that can be on any specialty. I have friends who've gotten into CRNA school from burn ICU, neuro ICU, neonatal ICU. I think that it's just in your best interest to set yourself up for success. That being said, I chose to work in CVICU because I really appreciate the hemodynamic monitoring that we have exposure to that you don't necessarily have a lot of experience with or hands-on exposure to in other ICUs. So a reason that I chose CVICU, even though I was formerly a surgical burn technician, was that the patients still come out of the operating room in the operative state. They are still paralyzed, they are not reversed yet, you are doing resuscitation in the ICU. It's really a continuation of that operative state. So you really get that hands-on post-op surgery recovery experience. You are giving blood products, you're giving fluids, you're messing with the inotropes, and you're looking at your swan numbers, you're shooting wedges sometimes, or you're keeping a really close eye on their cardiac function. And that's part of why I chose CVICU. I don't think that you need to be trained on ECMO to be a CRNA. I just liked that in the CVICU, they have a lot of Swan Gaines catheters, and I'm having a lot of exposure to those hemodynamic monitoring devices. And I think that that was very helpful for me, especially as a baseline, because I personally was able to start traveling after my year of experience in the CVICU, and I believe that it prepared me very well. It gave me a very strong base as a traveler, and I felt that I was able to take any patient from any patient population, aside from kids. I don't work with kiddos. I want to bust a myth that is super common. The level of trauma designation does not matter. If you are working in the cardiac surgery ICU, the trauma level designation doesn't have anything to do with your patient population. The level 1 trauma designation, it's a set of rules that the hospital has to meet in order to be designated a level 1 trauma. To be a level 1 trauma, they have to have all physicians from all specialties in-house 24 hours a day or available within 30 minutes. And then it's like, do you have a neurosurgeon in-house 24/7? And do you hit X number of patient volume through your emergency room? That doesn't have anything to do with whether or not you take heart transplants. An example is, I know that Penn doesn't have the trauma center within the hospital itself, it's at a sister hospital. So it's not a level 1 trauma, but those cardiac patients are incredibly sick. And then the last thing to consider is, what are they going to train you on? Just because it's a huge academic medical center where they take heart and lung transplants, open chest, VA ECMO, all that stuff, sometimes they won't even train new grads on those devices until they've been there for a couple of years. And if you have a strict timeline that you're trying to apply to CRNA school with, they might not even train you on CVVH and ECMO at some organizations until after you would have already wanted to have left. For me, for example, I interviewed at a couple of CVICU programs as a new grad, and one of them paid $2.50 an hour more, and then the other one paid $2.50 an hour less, but they were going to train me on ECMO and heart-lung transplants. So I chose the one that paid less because they're going to train me on more devices and more patient presentations than the one that paid more. And I'm very glad that I made that decision because I was able to grow much faster that way. And I personally am of the belief that exposure to really critical patients is actually better when you're on orientation, because you have a preceptor who's right on your shoulder to offer advice and support and to ask questions, versus if you wait until you've been a nurse for a couple of years and you've been on your own and then they just give you ECMO for the first time. You're not necessarily in that same learning headspace, and you're maybe going to ask less questions than you should. So I think that you can teach a new grad anything, and I would recommend going somewhere where you're going to have the most exposure possible. I hope this was helpful. Subscribe. I am now publishing YouTube videos. I'm shooting for twice a week, and check out my blog because that's where I'm going to have written out guides of all of the stuff that we're talking about. And thank you so much for your support, and I will talk to you guys later.